Okay, magandang umaga. Good morning. So, before we start with our program proper, I would like to acknowledge the presence of our attendees. So, hindi naman kailangan tumayo, but we would like to also acknowledge the presence of our FMDS faculty, Professor Myra Oruga, the Program Chair of International Health, Masters of International Health. And of course, we have our faculty secretary. So siya ang nangangalaga sa ating mga grado, si Dr. Joanne Serrano. And of course, I would like also to acknowledge the presence of the family members also of our of Dr. Lorraine Evangelista. We have Mrs. Arlinda Evangelista, Miss Hedy, and also si Mr. Teddy Evangelista. Okay? Oh, meron pa ba? Showbiz talaga, no? And also, parang baka may makalimutan ako. I would like also to acknowledge also Dr. Araceli Balabagno, the N2 19.6 faculty in charge and former Dean of UP Manila College of Nursing. And of course, hindi ko makakalimutan syempre ang aking kaibigan at ang aking colleague sa Master of Arts in Nursing, si Assistant Professor Queenie Redulme. Ah. Ay, ma-showbiz pagdating kay Queenie, no? And of course, the multimedia staff. And of course, since tayo po ay online at live, I would like also to say hi and hello to nurses po ng Philippine General Hospital. Oh, hello. Okay, and also faculty din ng UP College of Nursing. Okay, meron pa ba ako nakalimutan? And of course, syempre ang ating mga students from N2 19.6. Okay. Okay, ang hina. And also we have from N232, Nursing Care for Children Practicum. Taas meron. And of course, we also have from N262, Oncology Nursing. At meron ding isa from other batch, no? From batch 2009. Okay, so kompleto na. Okay, para medyo cool. Anyway, before we start with our program, I would like to call on our faculty secretary, Dr. Joanne Serrano, for the welcome remarks.
Good morning, everyone. Nakakatuwa naman. Bihira kasi kaming makakita ng maraming estudyante face-to-face. Ang nakikita namin mostly ay online. So, natutuwa kami na maraming physical faces na nakikita ngayon. So, I would like to welcome everyone. Sino ang first-timer here? Parang lahat? Lahat ba to? Okay, so welcome to the UPOU headquarters. So finally, narating nyo tong headquarters ng UPOU. Usually, napupuntahan lang to pag graduation time. But you are very lucky. Prof. Rita Ramos organized this particular Let's Talk It Over. So I would like to welcome everyone to our headquarters. Just to give you a brief background about Let's Talk It Over. We have been holding this forum ba to? This sharing of novel ideas, and it is very timely that this particular topic will be shared with everyone. Although karamihan sa audience na physical ay from nursing, this is web stream, so many of our students or faculty members out there will also be able to benefit from this. Okay, so without further ado, again, welcome everyone, and I hope we will have a great Let's Talk It Over. Thank you, everyone.
So I'm honored that we were able to invite one of the best uh, nurses or nurse educators. So we have the introduction now of our speaker. Dr. Lorraine S. Evangelista is a professor and an associate director of the PhD program at the UC Irvine Program of Nursing Science. She completed her baccalaureate training at the University of the Philippines College of Nursing, cum laude in 1985, and received her master's and doctoral degree from UCLA School of Nursing in 1993 and 2000, respectively. Dr. Evangelista is a skilled clinician, researcher, and educator. She has worked in the critical care setting in several nursing roles for over 15 years. As a researcher, she is recognized nationally and internationally for her investigation into the care of patients with heart disease and the effects of this disease on the patients and family members. She has over 100 publications in medical and nursing journals on the adherence, self-care, psychological distress, quality of life, and health literacy. She received a 2.1 million grant from NIH, NHLBI to examine the effects of macronutrients on delaying the progression of heart failure and is a part of the UC system-wide consortium that was awarded 9.9 million to examine the impact of wireless technology on reducing variations in care of patients hospitalized with heart failure. As an educator, Dr. Evangelista is dedicated to using innovative educational techniques to enhance the utilization of nursing knowledge and promote the legacy of nursing to educate the next generation of scholars in creative and exciting ways. She has developed expertise in curriculum development, and integration of innovative strategies such as use of interactive software, self-directed learning modules, problem-based learning, and team-based learning into the nursing curricula to enhance traditional learning modalities. She is a recipient of the J.B. Sotejo Distinguished Alumni Award and is a fellow of both American Heart Association and the American Academy of Nursing. And also, I'm proud to also inform everyone that she's also the FIC, one of the FICs of N260. Okay, yes. Yun. So kasama ko po siya sa N260. Anyway, so let us all welcome Dr. Lorraine S. Evangelista.
Thank you very much, Ma'am Ritz. And thank you for inviting me to speak and share my expertise with everyone today. I know na everyone made this big effort to come all the way out here to Los Baños for this forum, so I highly appreciate that very much. Where is the presentation? Okay, so we're going to talk today about mostly evidence based nursing. What I want to try to accomplish is give you an idea of the importance of evidence based nursing. So, the title of the talk is Globalize the Evidence, Localize the Decision, Evidence based Nursing, and International Diversity. So the objectives are for you guys to be able to develop a spirit of inquiry. I want to kind of stimulate your interest in nursing research and evidence based practice, inspire increased involvement in evidence based practice innovations that will potentially improve patient outcomes, and finally, provide you with a framework that you can use to implement evidence based nursing practice. So, we're going to try to go through the step-by-step process para if you guys want to get involved in an evidence-based project, then you'll be able to get the necessary tools needed through this forum. Okay, so we go first to translational research and innovation in nursing. What does it mean? Can anyone, this is going to be interactive, so I'm not going to be the only one speaking here. So what is your definition of translational research? What is your understanding of it? I guess you guys have to go to the microphone. Can anyone give me a definition of translational research? The the other day on Monday, I spoke to the UPCN graduating seniors from their BSN program. They were very shy in the beginning, but they kind of really participated. So I'm challenging you guys now. You need to step up to the plate. What's translational research? Go ahead.
Okay, so in my own simple understanding, I think translational research, ma'am, is research utilization is putting research into practice.
Okay, that's good. Anyone else? Let me. Anyone else want to take a stab at it? That's excellent, but I'd like us to go into the meat of it. Would you like to? Yeah.
Yes, in my own opinion, translational research and expanding what my classmate had said before, it's research put into practice and in consideration with other factors in the environment like the hospital, the location, the patient, and other factors affecting the output of that research.
Excellent. Okay, great. So you know what really happens is both of the answers are correct, but let me kind of let it put things in perspective. When clinical trials are done, when basic science research is done, we call it efficacy trials because they're lab controlled. It's in a very controlled environment. So that research is looking at the efficacy of different innovations. Or if we're looking at pharmaceutical trials, we're looking at the efficacy of the drug. And then it goes up. So that's basic science research. Then we kind of bring it up one level to effectiveness and feasibility trials, which looks at the effectiveness of the innovation in a sample of patients. So we're talking about 200, 500 patients. When you talk about translational research, we're talking about implementation science. We're talking about communities. We're talking about nations. And so really what we're trying to see is whatever's done in the basic science research, we're now bringing it up a level higher and now implementing it in the community. So it's translating what we've found in these efficacy trials and in these clinical trials so that now we can try to impact population health. Does that make sense? Okay, so translational research and innovation in nursing. What do we want in the future and how can we get there? That's kind of like the topic that we're going to talk about today. One of the things that's key to helping us get to the level of being able to do translational research, and right now, NIH, National Institute of Health, is really offering a lot of funds, big funds, $2 million grant funds, in order for us to partner with global communities. So this is the reason why I'm stepping up to the plate. I'm starting to establish relationships with both the UPCN and UPOU because I'd like to be able to get a full scholarship so that we can start building international connections because it's good for all universities involved. And the other thing is we don't just want collaborations between the universities, we want collaborations between the universities and the hospitals. In the past, academic faculty, we've been told that we just know how to push paper, right? We're bedside nurses will always say, "Oh, she's a faculty school of nursing. They don't know anything about clinical bedside. They don't know what we do and how hard we work." And we're trying to change that. It's true that in faculty of nursing, we're evaluated based on productivity and publications and our research productivity. But the thing that we're trying to change now is we're trying to step down lower to collaborate with nurses at the bedside because it's the key to building a stronger professional nursing practice. So this is where you see the bridge here between the schools of nursing and the hospitals. It's a US model, but we're starting to adapt it in all the other nations. And why are we trying to do this? For hospitals, everyone is trying to achieve magnet status. Are you guys familiar with the magnet program? I see nods. Good. So the magnet program in the US, and it's now going to the UK, is all about nursing excellence. Different hospitals in the United States grow through a 3-year program of preparing to be recognized as magnet status, which stands for nursing excellence. You know, when they go through Joint Commission accreditation, it's looking at all disciplines: medicine, pharmacy, nursing. When it's magnet accreditation, it's just looking at nursing. So only like 92 hospitals are magnet status in the States. When you have magnet status, it's tatakya ng A plus. It's the best hospital that you can work at. That means to say nurses excel, and nursing retention is very high. So nurses only quit because they're going to retire, because it's such a good place to work at. That's what the hospitals are after. When faculty go to the hospitals, we help them try to develop evidence-based projects. The magnet program doesn't want researchers like us from the schools of nursing to be doing our research in the hospitals. They want us to encourage clinical nurses at the best bedside, at the grassroots, to be involved in the research. So hindi na ivory tower ang gumagawa ng research ngayon. We have the nurses who are taking care of the patients that want to initiate something to change practice to improve it. And then for the schools of nursing, what do we get out of it? Well, I always say I like the extra publications, because when I start working with nurses at the bedside, I tell them, let's start a project. And once they've had output from the project and there's positive outcomes, I make them step up to the plate and I say, let's publish your findings. Because the only way we're going to be able to share the wisdom of the things that we do is through publication. And so at first they get really overwhelmed. They're like, what? I only have an associate degree. I'm only BSN. I can't publish it. And I say, yes, you can publish, as long as you have findings that are going to add to the science of nursing. Then that's where you begin. Okay. So the schools of nursing are in this because we want additional publications, but also we're in this environment right now where clinical placements are very short. So we're competing against different schools of nursing to place our BSN and our master's students in hospitals. At least here I heard that like TGH only is open to UPCN and UPOU and St. Paul's. So there's selected schools that have privileges in different hospitals, which is good. In the States, we have to compete with all of the other associate degree programs in the community. So very few placements. And so when we can bribe them with our mentorship, then they give us more clinical placements. So in reality, it's like we're best friends with hospitals, and it's like you scratch my back and I scratch yours. Okay? So kanya-kanyang tulungan, magkakaibigan lahat. Okay, so developing a spirit of inquiry. This is one of the first objectives that I told you guys about. It all begins with performance improvement. And I'm sure because you guys are already all nurses, you guys have been involved in performance improvement programs before. So when performance improvement measures are not met, and performance improvement is based on NDNQI, HCAHPS, and PRESS-GAINI, there's certain standards and benchmarks that we have to meet. We have to meet 0% fall rates. We have to meet 0% hospital-acquired pressure ulcers. These are standards that are now established by the CMS, which is the Medicare Foundation in the States. When there are hospital-acquired pressure ulcers, not only does the patient not have to pay for their hospitalization, it's going to be in the next 2 years, it's going to get to the level where if patients develop pressure ulcers while they're in the hospital will have to pay the patient back. So it's getting to the level where hospitals are getting penalized. Okay, in the past, during my time, and I know I'm dating myself, we would still get away with getting reimbursed for patient hospitalization, but in terms of treating the ulcer itself, if it was developed in the hospital, we don't get reimbursed for that. Ngayon, we don't get reimbursed for anything. If the patient had open heart surgery, the open heart surgery is free if that patient developed pressure ulcer while they were hospitalized. And like I said, in the next 2 years, the new program is where it gets to the point where we have to pay the patient back if they develop a pressure ulcer in the hospital. So it's getting very litigation atmosphere on healthcare. And that's what we're kind of faced with. But you guys, because you're going to be the, the, the clinical nurses that will be mentoring the people at the bedside, you need to understand this. So when performance improvement measures are not met, then we kind of try to discover why are we not meeting them? What are the clinical practice guidelines saying? Is the policy that we have in place adequate enough that we're giving the best care possible? And if that's not true, then what we do is we do evidence-based practice projects and we look at the evidence. So when the evidence is available, then luckily we use the evidence, we implement what other people have implemented, and then we hope that we get the same results. So evidence-based practice is pretty much using the research that has already been done and implementing it exactly the same way that the original researchers did it so that we can get the same results. Does that make sense? If there's no evidence, then what do we do? So we have to, if there's no evidence for us to replicate, then we have to do the research ourselves. So a lot of times when nurses come to me for help and they tell me they're interested in a certain topic, I don't tell them right away whether it's going to be evidence-based practice or research. It's going to depend on what we find in the literature. Does that make sense? If the literature gives us um, if the literature has ideas that have already been done by other researchers, then we replicate it. A lot of times from new graduates, I'll get this, well, that's plagiarism, Lorraine, isn't it? I said, no, it's not. Plagiarism is when you copy what someone else is writing. But in research, it's okay to replicate. And when you're replicating, and in fact, it's okay for you to contact the original researchers. When we publish, we always have to give our email address and our contact information. It's because it gives you guys who want to know additional details about our projects that opportunity to contact us. A lot of time we are not able to provide all the details of our methodology because of the word count limitations when we're publishing. So it's okay for you to go, oh, I like what this researcher did. Let me contact that person. And a lot of times I get a lot of emails from Filipino nursing students, and I respond to them and I even give them a nudge. I'll go, good job, contact me anytime if you need further help. So it's very encouraging to do that. And most of the researchers will be like that. Okay, so there's 4 processes that make up clinical nursing, and I like to equate that to a stool. So in the stool, you have the stool is considered nursing practice, and the different legs of the stool include performance improvement, research conduct, research utilization, and then evidence-based practice. And we're going to go through them one by one. So performance improvement evaluates the work process in a cyclic fashion against established indicators. It's gone from different terminologies like quality assurance, quality improvement, performance improvement. What I'd like to do right now is kind of have you guys share what kind of quality improvement projects you've been involved with before. Let share with me what kind of projects you've been involved with. Have, all of you have worked in the hospital before, right? So what kind of performance improvement projects have you been involved with? Yes. He looks behind. No, you. Come on, it's okay. We need to participate, guys. This is informal. Does anyone want to share what kind of performance improvement project you've been involved with?
Good morning, everyone. In our hospital, we have created this pre-operative checklist for our pre-op patients. So last month, we've just concluded with our research, and we're utilizing this protocol to every pre-op patients. And then this is to decrease. We want to check if through this checklist if their anxiety is relieved or not.
That's excellent project.
So
And
last month we've just concluded with the research, and as a group, like for example, when we group the our patients according to age, there was no difference at all. But when we grouped all the patients, including all the age, civil status, or uh, level of educational attainment, and there was a difference in that after we have delivered this preoperative education to each patient, there was a decrease in anxiety.
that's an excellent project. Actually, what that is it's an evidence-based project now in the beginning, and then when you continue to adapt whatever teaching you're doing, then it becomes performance improvement. So it's excellent. You need to publish that. Okay. Anyone else you know want to share what you've done before? Which hospital was this at? Oh, St. Paul's. Okay. St. Paul's Hospital. Anyone working at PGH? Are we doing anything there? Okay. Hey.
Actually, ma'am, when I was working abroad, I worked before in Dubai.
Oh,
So I am very active with the wound management team.
mm,
So we have conducted a research for a patient with pressure ulcers. So we have surveyed the patient with in the ICU. So from that, we have devised a protocol for the ICU to follow. So the result was very promising.
and what did the protocol include?
It's more on the assessment
Good.
for the patient who comes from the ICU especially. And even for this patient who comes from the ER. So it should be screened and until the patient will be admitted.
Good.
Yeah.
Excellent. So these are, like I said, because of the graveness of the current litigation system, we need to try to really prevent those hospital acquired pressure ulcers. In fact, I think I've worked with other hospitals where the protocol includes hiring a turning team. Because nurses are too busy at the bedside, they'll hire a nursing team that they go from one unit to the other to make sure the patient is turned every 2 hours. They call it turning team. So good. These are good examples of some of the performance improvement projects that we have. Research conduct, on the other hand, like I said, this is when you have to start from ground bottom and you come with a research question that hasn't been studied before, and you utilize the research methods, a systematic approach to determining whether an intervention is effective or not. So research conduct uses rigorous methods, including a series of orderly sequential steps. Research utilization, on the other hand, I told you guys it's one of the legs of the stools, but in reality, the term research utilization is phased out already because they came out with the terminology evidence-based practice. Research utilization is using research findings from a study, and because evidence-based practice is also the same definition, research utilization is actually part of that evidence-based practice definition. And in fact, what evidence-based practice is, like I said, it includes best available evidence, clinical expertise, and patient preferences. So not only best evidence, research utilization, best evidence lang eh. In evidence-based practice, we include clinical expertise and patient preference. So what is clinical expertise? Clinical expertise is systematically developed statements based on best available evidence to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. It's usually developed and endorsed by clinical experts in the specific field of interest. You guys have heard about clinical practice guidelines, right? You know how we have clinical practice guidelines for heart failure. We have it for coronary artery disease. I'm actually one of the two nurses who sat on both committees to develop those clinical practice guidelines for the American Heart Association. So it's a big privilege na someone who graduated from the Philippines is there in the US representing the entire nation in terms of nurses. So when it comes to heart disease, it's kind of a privilege for me to always be invited to become one of these nursing members to represent our profession. So if we have best evidence, we also have clinical expertise. And sometimes clinical expertise can be based on just being an expert in the field. We don't really have to have the research to always back it up. In fact, so evidence-based practice, if you have a anesthesiologist or a physician in your hospital who's the best in the nation and they know how to treat certain diseases well because they've been experts in that field, then we respect what they say. And that's the difference between evidence-based practice and research utilization, because we can rely on other people's expertise. Does that make sense? Just like when they say, we're so used to turning patients Q2 hours, right? And when you say, well, where's the research to support that? Sometimes we don't have it. We just learned it traditionally. It's something that we know prevents pressure ulcers. So we've learned it through good clinical practice guidelines. Then one of the other contributions to in evidence-based practice is patient preferences. We want to take into consideration patients' point of views. In most of the research studies in the US now, it's paramount that we include patients in the decision-making process. So whenever we want to get NIH funding, we have to have a specific aim that will say patient opinions will be elicited to determine whether the intervention works or not. So parang two-tiered level. We look at how patients feel about an intervention before we go into the effectiveness trials. So a lot of times we get patients to tell us how they feel. Parang qualitative research, focus groups. And then, like I said, best available evidence. It's probably what you guys have had to do in your research classes. And there's different levels of evidence. We'll notice here at the lowest level, you'll have expert opinion in textbooks, case reports. These are all levels of evidence. But then at the top of it is you have systematic reviews and meta-analysis. So systematic reviews and meta-analysis are pretty much processed data. Someone has done the summary for you. So you don't have to start from scratch. So if you get a systematic review and meta-analysis, then that's the best kind of evidence that you can use to establish a project. They will usually say, yes, it's very good to implement telehealth program in patients with heart failure. And then it's a simple go for you to say, well, a majority of the research in this area show that it's effective. So you can go back to your hospital and say, the research shows that it's effective, so I'm going to do the same thing, right? I kind of always like to equate levels of evidence with levels of chocolate. You have at the bottom, you have Nestle's Quick. And at the end, you have Godiva truffles, which is the best. I mean, you pay $20 per box of Godiva truffles. To the Filipino community, when I do this lecture, I always like to include chocolate because it's my favorite. But then when I have the US audience, they're like, what's chocolate? But chocolate is chocolate. So evidence is evidence. Hindi natin i-etchepwerang low-level evidence because it still contributes to our nursing science. Does that make sense? Okay, so let's test your knowledge. I'm going to ask you guys and see whether you understand the differences between the four legs of the stools that I just talked to you about. The first question is monitoring of ventilator-associated pneumonia, VAP rates, in an intensive care unit show that the VAP rates have increased in the past few months. Is this evidence-based practice or research utilization? Is it research conduct or is it performance improvement? What's that? Excellent. Good. So it's performance improvement because we're just monitoring and we notice while we're monitoring that the rates have gone up. Excellent. Okay. As an RN, you work with other staff colleagues and form a team that conducts an extensive review of the literature and review of national guidelines on the prevention of VAP as a first step. The systematic review reveals ample evidence to support the implementation of new evidence-based practice. So that includes head of the bed elevated at 30 degrees, use of special ET with a subglottic suction port, and eliminate routine ventilator circuit changes. What is this? Good. Evidence-based practice. Good. And the giveaway to evidence-based practice is that you've conducted a systematic review. Good. Okay. There's research gaps in the literature related to two areas of prevention of VAP: insufficient research on whether oral care decreases VAP and which method for providing oral care is best. What would you do? Research conduct. Good. Now you're participating. That's good. Okay, last. After incorporating all of the evidence-based recommendations for decreasing VAP in practice, the unit is still experiencing a high rate of VAP. Additional monitoring of practices is needed to determine compliance with actual EBP recommendations. Good. Excellent. Good. Okay, so we're going to go now to what is your role as staff nurses in research and evidence-based practice. We know first and foremost that your role is as a clinician, and you have sub roles of being a leader, a risk manager, a consultant, and an educator. But one of the new roles that we're asking you to take on is as a change agent. You need to be very proactive in change because there's always room for improvement. So why change? One of the books that I really love is a book called Who Moved My Cheese? Has anyone read this book? Do you want to share with us what the book's about? A short synopsis.
Actually, I read the book like a very long time ago. So, but what I can remember is the lesson that I learned from the book is that because the story is all about three different kind of mice, I think, and one was already content of getting a little bit of cheese and then eating it for the day, and then same goes on with the other days. And the other mice was wise enough to think that maybe if I move from this room to another place, I can get a bigger cheese who can feed me for a lifetime, something like that. So it's always I think the most important lesson that I learned from the book was that change is constant, and you have to embrace that change if you want to live a better life. Or
It's an excellent synopsis. She should get extra points. Who's her instructor? Excellent. Okay, that saves me having to summarize. So basically, what we're trying to say in the book, if you guys have, I mean, if you haven't read it, once you have a time to have a relaxing afternoon, try to get the book and read it. But what it's trying to say, like it was shared by your classmates, we need to move with the cheese. We need to change because the quicker we let go of old cheese, the sooner we find new cheese and better cheese. There's so many good cheese out there. But if we're content with what we have, then we're going to be stagnant. There's not going to be an opportunity to make a better profession out of nursing. And you know, we've gone so far from being what we were in the World War years, where we were just cleaning bedpans and cleaning floors. Now nursing is a profession, and we have a science all of our own. In the past, we've been guilty of borrowing science from medicine, from sociology, from social sciences. Well, now we have enough nurse scientists to start building our own research, and then we're trying to encourage all the nurses to be familiar with evidence-based practice so we can promote more science in nursing. Good. So building an evidence-based practice. A lot of time when we hear that terminology, everyone just freaks out. Oh, I don't have time. And 12-hour shift, I don't even have time to pee. I don't have time to eat my lunch or my breakfast. And we go home so tired because we're constantly just moving to take care of our patients. So do we have time to conduct evidence-based practice? A lot of nurses at the bedside will come to me to say, Lorraine, we don't have time. And so I tell them, well, it's all about really changing the culture in the hospital to where we can support the nurses so that they do have the time. Okay? So what are the common challenges of embracing a spirit inquiry? A lot of time we underuse the evidence we misuse the evidence, or we don't use the evidence. Let me kind of give you a few examples. Okay, so underusing the evidence. One of the best examples of underuse of evidence is hand washing. What is the benchmark for hand washing in terms of NDNQI? We have to be 100%, right? In fact, most of the hospitals, I'm not so sure how PGH is set up, but the hospitals that I work at, every patient room, when you come out of the patient's room, they have the disinfectant already. You have that now too. So excellent. But do we still do it? A lot of times when you have secret, what they call them is they have secret observers that are not nurses. They watch nurses walk out of the room and totally ignore washing their hands or disinfecting it. So we know how important it is to wash our hands, but we still don't do it. And so in the States, we've developed evidence-based projects where peer pressure is kind of what we utilize in order to, if a nurse walks out and hasn't washed their hands, one of their colleagues will go to them to say, hey, look, we observed that you didn't wash your hands. And so medyo nakakahiyaan. And of course, you don't want a peer to tell you that you haven't washed your hands, so the compliance rates go up. So, but it's very common in a lot of hospitals where hand washing is still not being practiced. Or they wash their hands real quick, right? Sometimes when we go to the restroom, we'll be in the restroom with a lot of people, and we hear they just flush the toilet, they go out, and we're like, oh, what happened to the hand washing? Okay, or sometimes we misuse the evidence. How many ICU nurses do I have in the audience? Okay, now they don't want to even raise their hands. Okay, does anyone know what this is here? Oops, that got advanced. Does anyone know what this is? Good guess. They're actually rectal tubes. Does anyone know what rectal tubes are? When I was in the rectal tubes first came out in the 1990s, and I was an ICU nurse, and we all, you know what, it's the funny thing is when you're an ICU nurse, it's surprising how we have to change bed sheets. We have to change the patient's sheets every day. When at home, we don't even change, at home, we don't even change them for months, right? But for some reason, nurses are so neurotic. We have to change the sheets every day. And of course, when we have a patient with diarrhea, we don't want to clean up after them. So during my time in the ICU, if the patient had some sort of diarrhea, we would put the rectal tube in. A rectal tube is like a Foley catheter. So when we put it into the rectum, we inflate the balloon. And so when they have diarrhea, it just goes into a bag. So it saves us all the trouble of cleaning up after them, right? But it's misuse of evidence because in reality, now the clinical practice guideline states that we only can use rectal tubes if the patient has had loose stools of like at least 5 to 6 times a day. So more than 5 or 6 times. If they've only had it once, balik tayo sa punas with washcloth, right? So we can't use rectal tubes because it's abusing them because it can cause a lot of irritation in the patient's rectum. We also, the other practice guideline for rectal tubes is they have to have pressure ulcer. So noong ICU nurse ako, we would say, well, we're trying to protect them from developing pressure ulcers and they have diarrhea. So every patient, if we had 16 beds, every patient had a rectal tube. Same thing with Foley catheter. How many times do we see Foley catheter in every patient? And then we tell them, it's an ICU, we need hourly INOs. Now the evidence shows Foley catheters are only used if they're clinically indicated. In fact, Foley catheters that are not clinically indicated, it's a performance improvement project in a lot of hospitals. If they're not, the nurses get dinged for it. So the nurse, if a Foley catheter is in and there's no clinical indication, then it needs to come out. So we can't misuse evidence to make nursing care easier for us. We only use the evidence if it benefits the patient. And then a lot of times we don't use the evidence. One of the examples that I was giving to you in the quiz that we were talking when I was quizzing you about the VAP prevention is there's bundles now in place, but a lot of times we don't use the bundles. I see the nodding of heads. So you guys are familiar with VAP prevention, head of bed elevated, oral care, and then we don't have to change the the circuit every day. I mean, like I said, it's so funny when RT would come every time at 5 a.m. They need to change the entire vent circuit. It's no longer a practice. We change it only as needed now. But sometimes we're not yet proactive and we don't use the evidence. You guys are already familiar with the bundle to prevent VTE, right? Okay, so a lot of surgical infections prevention, we use the bundles. We start antibiotics even before the surgery to prevent infections. I'm glad to know that even here in a third world country that we have you guys. I mean, I'm glad that I'm seeing the nods because at least I know that it's being taken accounted for. Good. So is change easy? A lot of times, like I said earlier, the evidence shows that nurses do not want to change because they know there's no time, they don't have the evidence, or there's too much evidence and there's conflicting data. They don't know how to find the evidence or to evaluate the evidence and synthesize it. And so a lot of times what I do now, like I said, remember that bridge between the schools of nursing and the hospitals, we go over to the schools of nursing to help them. Okay. So, but the biggest barrier to embracing a spirit of inquiry, does anyone know what these stalls stand for? You've seen it probably with monkeys. Okay, it's supposed to be see no evil, hear no evil, speak no evil. Well, a lot of nurses, when we talk to them about evidence-based practice, they'll say, see no evidence, hear no evidence, speak no evidence. And if you're going to be in this type of position, then it's pretty much walang pupuntahan ang nursing profession if we have this kind of mindset. Okay? So, there are certain myths that we have in practice that kind of also serve as barriers to change. One of the myths is we shouldn't fix a wheel when it ain't broken. It's a Southern terminology, medyo wrong grammar, but like I said, this is what we kind of always say. If it ain't broken, why fix it? A lot of old nurses, when they've practiced for 30 years, 35 years, sasabihin nila, when I was a teenager, that's how we did nursing and that's how I'm going to do it. I'm retiring next month, but ko pa iibahin, right? You can't get them to change because they've done it like that for years and years. There's a couple of series of articles that if you have time, I want you to look at, but it's about removing the sacred cows of nursing. And have you guys heard about that? So one of the good examples, I'll give you a few examples, that I'm going to open it up again to you guys to share some things that you can share with us. Installation of normal saline before endotracheal suctioning. Is it helpful or harmful? It's harmful. Okay. During my days, we all believe that when you instill normal saline, it will help because supposedly we thought it was easier to remove the secretions, but in reality it decreases oxygen levels and it increases the risk for bacterial contamination. And if you mix secretions and normal saline in a tube, it's like vinegar and water, or vinegar and oil. When you mix them, they don't mix, so there's no such thing that it liquefies the secretions. We just hear a lot of slurping because we're slurping out all the normal saline. So the clinical practice guidelines does not include installation of normal saline before endotracheal suctioning. Who's guilty of doing this though? Nurses, more so respiratory therapists. It's funny, it's their territory, but they're the ones that aren't practicing good clinical practice guidelines. Nurses are better, I think. Nurses will kind of tell the respiratory therapist not to do it anymore. Here's another one. Verification of proper placement of NG tube. How do we check proper placement of NG tube? Do we still instill the air? Okay, auscultation during insufflation. That's where we put 10 cc's of air to hear the. So that's not the proper way anymore. If we still do that, that's old. That's old method. It's not in the clinical practice guideline. About 5 years ago, we started doing testing of pH aspirated fluid every shift. So every bedside, we would have test strips, and then we would just test. If it's acidic, then we knew we were in the gastric. But that also got phased out. So we're back to the best method is still radiographic detention. Nowadays, they're trying capnography. Does anyone know what capnography is? Okay, so we're looking at dioxide levels. The only caveat to this is every unit would have to have their own capnography machine. So it's hard to convince hospitals that it's important to invest in buying a machine for every unit. What they don't realize is it's more expensive to do the X-rays all the time. But if you don't have the machines, then ang bagsak natin X-rays pa rin. But try to remember, if you guys are clinical educators, try to remember, do not encourage the auscultation during insufflation. The evidence doesn't show it's working. And then how about Trendelenberg position for hypertension? No more. Okay. When I first started as a clinical nurse, after I graduated in 1985, my specialty when I did my clinical rotation in UPCN was psych mental health. And then when I got to the States, so I worked psych mental health. It was easy because I knew it well. I mean, good communication skills, right? Mimi David was my psych instructor. Um, so I was good at it. But when psych mental health census went down, they would float us to the med surge unit. And I would freak out. And I didn't know, when we did that whole quarter in psych mental health, I kind of forgot med surge or ICU. So a lot of times I got in trouble because I was supposed to insert a Foley catheter in a med surge patient and I didn't know how to. Sabi ko sa loob ko, in the Philippines, we don't insert Foley catheters because it's indwelling forever and ever, right? In PGH, when I used to be a student, all the every patient had a Foley catheter and they had it inserted even before they were admitted. That's how long it was ago. So we never had the experience. We had to practice on each other to put NG tubes in and IVs and IM shots, but we didn't want to ear or showing symptoms of an ear infection, then you don't start them on antibiotics. Excellent. Great. Any others?
Using of warmer during blood transfusion.
Using
Using of warmer. We have to put
Oh.
example if we receive blood from the blood bank that is called, we are using warmer prior to the transfusion of blood to the patient.
and now it's not a clinical good. Okay. I think and labor and delivery, how many of you still use alcohol to clean with the cords, cleaning the cords of an infant? A lot. I think when I was taught at PDH, we had to clean the cords. When they cut the cords, we would clean it with alcohol. And now the clinical practice guideline is no alcohol, just regular soap and water. One more example of some things that we do because we do it out of tradition.
Actually, this I've learned this just because I'm an MSN major, and it's actually still practiced now, but I think it's being phased out. Is the new essentials newborn care, because like before we are so used to like immediately washing the baby, but now there's it's like changed to delayed washing so that there will be prevention of hypothermia, and also to promote first infant and the mother attachment
Bonding,
in the
yes.
process to initiate bonding. And then there's also part of the ENC is that also the delayed cord clamping and the cutting, because before we used to immediately clamp it and then cut and separate the baby from the mother. But right now there's an evidence that shows that if you delay the cord clamping, they found out that there's still pulses or like blood flow. So if you delay it, there's going to be prevention of anemia in the newborn.
That's good. That's a good example. And see how it's backed up with clinical reasoning. So a lot of times things that we learned may have changed and the science is evolving. That's what we need. So like I said, there's things that change and we have to be on top of things. We can't keep saying, well, that's how I was taught in nursing school. If the science has changed, it's because we're trying to keep on top of what's best for our patients. Okay, the second myth is thank you for all the contributions. Those were excellent. The second myth is change is easy to adopt. The example I have here is a little girl copying an ape or orangutan or whatever. I'm not good with animals here. But is change easy to adopt? It's definitely not easy to adopt. What I have here, and you guys may have seen this before in your research classes, is diffusion of innovation theory and the innovativeness of adopters. It will show you here that you'll always have a group of innovators that are very excited about change. They're usually the new grads. They're usually students like yourselves who are in school and you've learned something in your research class and you want to go back to your hospitals and you're going to go, I want to initiate a change project. Hopefully this forum will help inspire you to do that. This is you're the innovators, right? And then you have some friends or some people that are very supportive. They're called the early adopters. They're like, we'll support you, Troy. We'll support you, Maria, or something. And then when you get the approval of your administrator, a lot of the early majority and the late majority will follow suit because there's going to be some administrative implications. If you don't do it, you get in trouble, right? Or we're going to write you up if you don't do this. So you get all of the others following, but you always have to remember that there's 16% of the population that's always going to be called the laggards. They're the ones that don't want to change. And it's almost like what I want to tell you at this point is don't waste your efforts on the laggards because no matter what you do, they're just going to ignore you. So if you win over the 94% of the other key players on your unit, then be happy about that. Okay. So the laggards are the nurses that are just going to retire in 1 week, or they just want to wait for their son to graduate from college and they're going to retire and they don't care about this new innovation that you want to introduce on their unit. Let them be. They just want to stop working. So when we want to implement a change, we need to be able to carefully plan it ahead of time. We need to be able to work with willing volunteers. And then we want a change that is not going to be lengthy or complicated. We don't want to, hindi ba sa beauty pageants, it's always, I want world peace. We don't want world peace. We just want something that will improve care on the unit we work on. If we stay if we focus change projects on a small unit, they're more likely to be successful. Okay, we want to change only what we can change in our capability. World peace is good. If it does work on one unit, then we can go hospital wide. But, and this is where I said, when you start publishing something that's been successful, like it was shared with the pre op checklist and the pre op education, when we publish it, then at least other hospitals will go, oh, they did this in a hospital in the Philippines and it worked. And so they can replicate what we did. Okay. So, myth number 3, if you can't win them, you join them. Nurse Tunes is one of my favorite comical strips, and it's about Nurse Ruth. Hopefully, is there a Ruth here? Nurse Ruth, there's no Ruth. Good. Okay. Nurse Ruth is a lazy nurse who thinks she knows it all. Okay, so it's funny when you guys seen any of the comic strips with Nurse Ruth? Okay. Well, this is one of them. So here she goes. Everywhere I go, I hear people complaining about their jobs. When I stopped to get coffee at a Quick Mart today, all the employees were complaining. And so her supervisor goes, I hope you told them that their behavior was inappropriate. And she goes, heck no, I joined in. What fun. So instead, and we do this a lot. We have a group of whining nurses. And what do? We go join them and we go, oh, oo nga, yung supervisor, ang sungit. Lagi lang gusto palit ng palit, right? We complain about management and we always say they never understand how hard we work. But really, what your role needs to be is to, when people are whining, don't join them. Tell them to turn their energy into something more productive. Okay? And then myth number 4, this is the last one. Nurses are just like any other hospital worker. This is the comic strip. The patient's calling nurse, and then the janitor goes, sorry, dude, nurses are in short supply. I'm the janitor. How can I help you? So the myth is nurses are irreplaceable. We cannot be replaced by a janitor. We are unique and we need to be able to show our uniqueness. So we need to be able to, like I said, magnet excellence is about nursing excellence. And so in order to achieve nursing excellence, we have to operate from a body of knowledge. We have to have our own science. We have to base practice on evidence. We have to collect reliable data, and we have to base our decisions on sound data. We don't just practice because that's how we were taught to practice. Okay, strategies to build a research capacity. We need transformational leaders. We need staff involvement, nurse champions. We need unilateral assignments, a vision and mission, and time and resources. Does anyone understand what unilateral assignments is? You know how a lot of hospitals in the very beginning, it's so top heavy. You have all the management up here, you have nurse managers, you have assistant nurse managers before it gets down to the nurses. Well, the key now to magnet excellence and nursing excellence is a flatter organization. Why do we want a flat organization? What you'll have is you'll have a nurse manager that covers 4 different units. And the common response I get from nurses when I ask this question is they're going, cost savings. They don't want to pay any more nurse managers. That's not the right response. The reason why we're doing flatter organizations is because decision making is now at the level of the bedside nurses. We're trying to encourage a lot of unit-based practice councils, which are staff nurses, to make the decisions for their unit. The nurse manager role is only to supervise now. Does that make sense? So unilateral assignments is the way to go now. Flat organization, hindi top-heavy. Kasi doon napupunta lahat ng dollars pag top-heavy eh. If they move to a flatter organization, then you have a lot of the nurses at the bedside being more empowered to make the change. Okay, creating an evidence-based culture. Like I said, we can't change overnight. You can't go back to where you work and go, I heard this, I was part of this forum where Lorraine Evangelista said I can be a change agent. It doesn't happen overnight. You can't create change overnight. In fact, you need to create change from the organizational level. So it's about creating internal expertise. and educating frontline staff. So we need to create a teamwork approach na medyo like the herds that we have here, like elephants and like the meerkats that you have. Staff nurses need to be involved. Like I said, a lot of times what they want us to do as researchers is to come and bring our research to the hospitals. Now we don't, the hospitals don't get points for researchers coming to do their research. They will disqualify the hospital applying for magnet status if it's PhD prepared nurses doing the research. They want staff nurses to be involved, okay? So you're supposed to be involved in collecting the data and then making sure that it's implemented well. We want to create evidence-based experts and champions. When you have carried out a project with the mentorship of someone who's an expert in research, then you help the next person behind you. So it's like the dog and the cat here. The dog already knows how to drink water, so the dog is helping the cat drink water. That's the same role that you have to play with nurses. We have to, diba, we're always guilty of nurses eat their own young ones. We need to change that whole culture. We need to, a lot of times we're guilty of it. We have a new grad who doesn't know anything, right? And we look at them, we're like, more trouble. It's like more trouble to train the staff nurse that doesn't know anything. Well, if we don't train them, who's going to take over for us? So we need to change that mentality, and we need to be able to support our younger nurses, okay? So steps to conducting an evidence-based practice. I'm kind of like wrapping it up. So how do we create evidence-based practice? I kind of told the senior students, the BSN students at UPCN the other day, it's almost like there's different models. We have the Iowa model of evidence-based practice, Rossworm Larrabee model, but no matter how you look at it, the steps are still the same. It's like the nursing process. It never changes. You assess, you diagnose, you plan, you implement, you evaluate. And it's almost the same thing. And by the way, I noticed you guys are taking pictures of the slides. I'm sure Ma'am Ritz will give you copies of, she'll upload the slides for you guys so you don't have to take pictures. Yeah. So the first thing is when you decide what change you want to do, you want to select the topic that you want to focus on. Like I said, when you select the topic, it needs to be something the organization and your department will approve. Remember, any change involves resources. Resources is money and time and equipment. So you can't do change on your own. You need to get approval from your unit director, your department, and your organization. So select the topic that's doable. Some sources of clinical topics include problem-focused triggers like risk management data, performance improvement projects that are not meeting benchmarks that we talked about. Like I said, catheter-associated UTI, CLEBCs, all of these topics, fall prevention, anything that's not meeting the benchmarks for performance improvement, those are good topics for evidence-based practice model. A lot of the topics now that problem-focused triggers in the US now is delay time in discharging patients or frequent readmission rates, especially for CHF. You'll see a lot of what I publish is about how to reduce readmission rates in heart failure patients because we don't educate them enough when they get discharged. And so they come back and they have the same symptoms, right? So these are kind of good topics for us to select. The example that was given earlier about pre-op teaching, that's very, very common evidence-based practice topic right now. Not only in pre-op patients, we're starting to do it for patients, postpartum women. We want to, before they have their baby, we want to do the not pre-op, pre-baby, what do we call it? So prenatal, that's it. See, I go into ICU and I don't know anything else now. Specialization is something not that ideal sometimes. So prenatal care, we have to educate them before they have their babies or before their C-sections. And sometimes we totally ignore that. So we're going back to the basics of having a checklist and what is it exactly we want them to take home with them. Okay. Then we have to formulate a clinical question. Are you guys familiar with the PICO format? Okay, you're all nodding. Good. So when you create a question, we want to put it into a clinical question Because remember, in research, you always have to answer a research question. In evidence-based practice, you always have to answer a question as well. So the PICO question is patient population, intervention, comparison, and outcome. And so here's an example. In adult patients undergoing joint replacement surgery, what is the effect of integrating a teach-back approach to standardized discharge education, which is using Crane's education tool, which is your patient education, versus standard discharge education alone on patient satisfaction and knowledge for discharge? This is an example of a PICO question. Let's try practicing one together. A 70-year-old woman who has had open heart surgery has been very ill for the last 3 days, requires mechanical ventilation and a number of inotropic and vasoactive drugs. Despite turning and positioning, she has developed a small pressure ulcer at the posterior occipital region. Several nurses come to you to ask about how to prevent further pressure ulcers. They heard about a new type of mattress bed that the skincare specialist discussed in a recent class, and they would like to try the mattress on high-risk patients. What's your PICO question? Should I go back to the thing? Okay. Who wants to try? This side. I've always had volunteers on this side. Let's go on this side. Okay. Come on. Come on to the microphone.
Post-operative patients, ma'am,
Okay.
would be the population.
Just go ahead and state it as one question. In
The population would be post-operative patients.
Okay,
Yes.
good. And what's your intervention?
Intervention, use of this new mattress, maybe air mattress,
Okay, good. Compared to
compared to the ordinary mattresses.
excellent.
And
On
outcome and compared with this air mattress, and the outcome will be free from bed sores.
Okay.
pressure ulcers.
Okay, that's excellent. So good. So in critically ill patients, are low pressure mattress beds with positioning more effective than usual foam mattress with positioning and preventing pressure ulcers? And pressure ulcers, we would observe them based on stages, discoloration, partial or thickness loss. Good, excellent. Okay, after we've established a clinical question, the next step would be lit review. And you guys have done that. Which class have you done lit reviews in the master's program? Research. So you've done lit review. And we start usually, we look at a policy or a clinical practice issue. I always tell my mentees to look at the hospital policy on a certain procedure. We don't want to start and look at what's out there. We want to look at what's, remember, I always say we want to focus on what the organization practice. So I ask them to pull out the policy on newborn care or policy on discharging patients with heart failure. And then we have to conduct the lit review. This is where we waste all the paper copying all the articles that we think is going to be helpful to us. We have to read. What I tell students or nursing that I'm mentoring to do is read the abstract. If the abstract does not look like it's going to contribute to what you want to do, then put it in the out file. Save the articles that seem like some of the interventions they're doing and their testing is what you want to implement. Those are the ones you want to put aside. Okay. These are a few lists of other evidences that you could look at. And they'll be on your handout. Like I said, if you can go for the best evidence at the top, go for it. Go for the, remember what Lorraine said, go for the Godiva truffles, okay? And once you've selected, like I said, meron akong example na one mentee in the beginning wanted to start an intervention about something, and I can't remember what it is, but she wanted to do something, and I told her, okay, let's look at the evidence. And then we did the lit search, and all the evidence was saying that whatever she wanted to do was not going to be effective because all the research and clinical trials didn't support it. So after we did that, I asked her, so what are we going to do next? And she goes, I still want to do what I want to do. And I'm like, are you kidding? I said the whole point of this whole mentorship that I'm doing for you is that if the literature doesn't support what you want to do, you're not going to insist on doing it because it's going to end up being a dead end. So you want to be able to come in with an open mind. If the literature doesn't support what you want to do, no matter how innovative it is, it's not what you're going to do. You want to do what works already. That's what evidence-based practice is. So you'll see here the two little cats. They've used all of the knowledge they've gained from their lit search in order to plan a way to get the goldfish. That's what you need to do, okay? So your intervention needs to be clearly outlined step by step. Like I said, if the article that you found that's very helpful is not detailed enough, contact the author. Tell them to say, I'm a master's student at the UPOU, and we're supposed to implement an evidence-based project. I read your article. I'm very impressed with the intervention that you implemented, but can you give me additional information on how you implemented it? Can you share your materials and documents that you use to collect the data afterwards? 99% of the time, they will respond positively. You'll have that 1% of the population who are I, me, myself. They're like, I don't want to share. It's my project. It's what if I don't know what's going to happen. 1% of the time. Okay. So feel free to contact authors if you like what they did so that you can get additional stuff. It's stupid to have to reinvent the wheel and try to type up another questionnaire when you can just grab it from them. Okay. And then you want to be able to clearly describe the innovation. Why is it so important? When you want to get buy-in from your colleagues at work and your administrators, when you want buy-in, you want to have it clearly outlined. You don't want to go, I think I'm going to do this, or maybe I'm going to do this. You want to have step-by-step, this is how we're going to implement it. A very common innovation now in the States is the use of admit discharge nurses. Remember, I told you a very common problem is there's always a delay in discharge, which delays admission from ER and the PACU. So what we're trying to do now is we have a team of 7 admit discharge nurses. All they do is they go to every floor to help discharge patients. That's the only role they do. So it relieves the regular nurses from having to do it. In the beginning, administration will say, what, 7 nurses? Do you know, Lorraine, that you're recommending an additional almost $100,000 of resources to go to hire 7 nurses? And I tried to tell them the evidence shows that this 100,000 will pay off in less than 6 months, because not only are we discharging patients faster, we're even having happier patients. And remember, one of the biggest performance improvement in the States is HCAHPS. It's the Press Ganey. One of the questions is, how satisfied are you with your care? And the benchmark for that is supposed to be 90%. So when patients can want to ding a hospital, they'll just put very unsatisfied. It will bring the numbers down. And that's what it's public, it's transparent. Every hospital scores can just be found on the internet, okay? So if you have scores below 90%, if you're a patient that's unhappy with the hospital care, you just give them a very low score, and it will really it's a big blow to their scores, and it, like I said, it affects their reimbursement rates from Medicare and Medi-Cal. Okay, so a lot of times we want to look at patient satisfaction and money. So admit discharge nurses, it's starting to pay off. We might want to try to look at that here in the Philippines. Okay, see, these are just elements of an implementation plan that we want to include. But like I said, rather than keep stressing, all I want to stress is that we need to have step-by-step implementation process. Why is this important? When your project is effective and I tell you, okay, let's publish, when you publish, you have to be able to state step-by-step how you implemented the project, okay? So, what's really important to your success is forming a team. You want to be able to have a multidisciplinary team. You want to, if your project needs to be based on expertise, if you're going to do and you're going to try to recommend antiemetics for, I worked with a postpartum nurse who was very concerned that a lot of her patients who came out of C-section was constantly nauseated and vomiting. And so, excuse me, she felt that that the the patient and the babies can bond faster if the moms were medicated in surgery. So she proposed giving antiemetics before, during, and after the C-section, and was able to show that moms would bond better with their kids because they wouldn't come out nauseated. And actually, she was very shy. She was from China, and at first she was like, Lorraine, I only have a BSN. Can I really carry out this research project? When I helped her with that research project, she published it, and she received an award from A1. A1 is, I'm not Women's Health, but it's the biggest organization for women's health in the US. So she received like a new investigator award for proposing giving the antiemetics before, during, and after. But my whole point of bringing that up is she had to bring in the anesthesiologist to support her. So your team will depend on what you want to do. You can't go into every surgery to go, I want to give antiemetics to everyone. She had to pull together the medical director, and the medical director called all the anesthesiologists. If there were 20 of them in that hospital she worked at, 18 of them supported her. So there were two that we would say every time they're the anesthesiologist, we can't do the protocol. But all the other 18 supported her, and that's why it was such an effective change project. Because as a postpartum nurse, she said she didn't have to worry about getting compasine or scopolamine for the patient because the patient would be fine coming out of the C-section. Okay, so we're wrapping it up. Ingredients for a successful EBP project is a not me, but a we attitude. You can never do anything alone. It's all about teamwork. Uh, there's a difference between interest and commitment. A lot of times when I get introduced to do these forums or these lectures, people come to me going, I want to publish too, Lorraine. And I tell them, okay, let's start from step one. Let's not go to step 10. Step one is you want to have to be able to commit to a project first. If your project is successful, you've done it, then by all means, then we can publish it later. But don't come to me going, you want to publish when you haven't even done anything. So start from the bottom. It's not about bragging or trying to be a hero in the profession. It's about trying to act and make a change, okay? So nobody can do everything, but everybody can and must do something. If these animals can help each other reach a common goal, my message is we as humans and we as nurses should work together to also try to achieve better patient outcomes. So thank you very much. My email address is here. Please feel free to contact me if you want any guidance, if you want to initiate a change project. Thank you.
Okay, thank you so much, Dr. Lorraine. So it's your turn now to ask questions. But before that, let me just review some objectives that were posted in the beginning. We have the first one is develop a spirit of inquiry. So that was the first objective. We have stimulate interest in nursing research and evidence-based practice. Okay, smile. Okay. Third, inspire increased involvement in EBP, innovations that will potentially improve patient outcomes. Yes, okay. And lastly, provide a framework that can use to implement an evidence-based nursing practice project. So these are the four objectives that we have for this forum. So we're given at least 20 minutes or 15 minutes time for you to ask questions. Otherwise, Dr. Lorraine will ask questions for the audience. So ano mas gusto niyo? Si Dr. Lorraine na magtanong? Okay, anyway, if not, I guess a question, perhaps I think Dr. Lorraine will be glad to hear from you some insights or reflections from that forum? Hello? Yes, okay. So, volunteer? Ano? Okay, Miss.
Hi, ma'am.
Hello.
First of all, let me thank you. You have a very enlightening and informative
Oh,
lecture.
thank you.
Yes. My question is about the Philippines as a third world country related to the nursing practice. Uh, we know that the United States of America is a first world country. So, economically, socially, and politically speaking, the health system delivery there is different. Okay, but with your advocacy in the evidence-based practice, the better gets best. Now, my question is this: it may be broad, but I just want to get your personal note. What is your opinion or prognosis about the EBP projects, the current and the future of it in the Philippines as a third world country having this kind of healthcare delivery system? And what would be your one best advice for our nurse leaders so that they will not lose hope in adopting this kind of projects for the betterment of the nursing industry?
That's an excellent question. And I think part of me also really wants to get more involved in our healthcare system. And this is the reason why I'm trying to apply for a Fulbright scholarship. Because, like I said, change will not happen overnight. If I had 6 months to be able to come here and work with at least the top universities, then I think I would um, be able to inspire more nurses to support evidence-based practice. It's a culture change. We have to think differently. Nurses will always say, I don't have time for research. But really, this is not research. It's trying to really implement what's already effective. It's trying to change the way we practice based on the evidence. So I would like to, I know, like I said, a lot of my examples are US based. And one of my personal passions now that I'm close to the retirement ages is to be able to bring back and give back to my country.
And then I have another question, the
Okay.
last one. Yes, thank you for that. Do you think that with the current, this may be a little bit off tangent to what we are here right now. Do you think that the current political condition of the country will have a drastic effect on the way EBP projects will be implemented by the nurses? Like, for example, I don't know if we have already a seat in the Congress, right? But if we get the right support from the government to fund these researches and the projects, don't you think this will be a good idea?
I think so too. Like I said, we need to start small. I mean, I think we need to get buy in from the organization, the hospitals we work in first before. I agree that governmental support is important, but I think that if we can show small changes, if we can move small stones, then, we shouldn't try to move the mountains first. Small stones are good. I agree. I'm at the level where I'm involved in healthcare policy change in the US. And I think that is the way to go. But I also believe that we need to make a difference in our workplaces first before we can impact national health, the nation's health.
Thank you very much, ma'am.
Okay.
I would just like to ask for your advice, like when implementing evidence-based practice into, like implementing changes at our, say, our facility to try and um, comply with CMS requirements. And we're dealing with staff nurses who are mostly laggards. I'd say 90% of them because they're long-time staff nurses at our hospital. So when implementing like pressure ulcer prevention and infection control, and they won't comply with those, and we always get cited by the CMS. So how would you approach those kinds of laggards?
Okay, that's a very good question. In fact, I told you guys my daughter is a nurse practitioner, clinical nurse specialist. She's only 26 years old. So her first job as a clinical nurse specialist was to implement a few evidence-based practice projects at the hospital she got hired at, and she had to work with the same conditions that you had. All the seasoned nurses, that didn't want to change because they were so comfortable with their practice already. And she would come home to me crying, going, I don't want to be like you anymore, mom. And I'm like, why? And she goes, because the nurses don't want to change. They just want to do what they've learned how to do. It's a big challenge. One of the things I told her too is that you can't come in as someone so young knowing everything too. You can't have an attitude of like wanting to change people overnight. You need to win them over. You need to be involved at the bedside to show that you care about them and that you're part of them and you're empowering them and not demanding of them. I had to tell her, I had to give her the mom daughter pep talk that nurses do not listen to young people like you who look like high schoolers that want to try to change our lives. And that's what you're doing as a young person. You come in with all these big dreams of changing what they're so used to. We can't do that. We need to empower them so that they're willing to make the change on their own. They need to recognize it's an issue that affects their units, and that if something were to be done about it, that it would improve their quality of life as nurses. So empowering them to be part of it is one of the steps. And like I said, it's not, I mean, the 90% are the skeptical people. It's only 60% that totally won't change you. That's what the research shows. It's pretty much, if you've taken your statistics, it's that end of the people that won't change. But the 90%, they're just trying to side with the people that are skeptical, and you need to just change their mindset.
Thank you very much.
Okay. Yes, Troy.
Different answer to her question.
Okay.
Terminate those people. Anyway, totally different question. I just wanted to hear what's your opinion about broadening or expanding the um, the RN scope of practice here in the Philippines, because as it is right now, and comparing the U.S., where the nurses are independent practitioners, like nurse practitioners, clinical nurse specialists, clinical the midwives. Um, do you think that the Philippines, with the need for more healthcare providers and clinicians, do you think that the Philippines should, I guess, have a much more different perspective wherein the RNs be more independent in their practices in the provinces or other places? Because I think that's going to be very helpful. And what do you think that the Philippines needs to do to get to that point?
I think what you're talking about is like nurse-driven protocols. Is that what you're saying?
Well, expanding the scope of practice, because right now we have a lot of nurses that are masters prepared or doctorate, and then but the limitations clinically anyway is very limited. It's still, if you have a BSN, your limited the scope of practice is the same as a doctorate or a master's degree. I mean, don't you see that, like in the States, as I said, you have a master's degree and then you have gotten your accreditation. You are a nurse practitioner and you practice independently. You see your own patients, you bill, you're the. That's what I'm trying to.
Yeah, that is a major challenge. And honestly, I don't know how we can best do that. Like I said, it's probably something I would also like to explore if I had the chance to be here longer and not just come and speak and inspire. But I'm not familiar with the healthcare environment here and the status of nurses. I'm just familiar with the fact that when I went to school in 1985, we all wanted to go to the States. There were only 10 students in my class, so we were the smallest UPCN group. So all of us were already in the States after like 2 years. So I don't have the answer to that question. I'm not familiar with scope of practice here. So unfortunately, but like I said, I don't think it's a dead end. I think we just need to look more positively at what we can do versus what we can't do. Let's go on our outing. I'm just kidding.
So, okay lang. So, at this point, I would like to call on Assistant Professor Queenie Redulme and Dr. Joan Serrano to award the certificate to Dr. Lorraine. University of the Philippines Open University, Faculty of Management and Development Studies presents the Certificate of Appreciation to Dr. Lorraine Evangelista as the source speaker during the Let's Talk It Over, Globalize the Evidence, Localize the Decision, Evidence-Based Nursing and International Diversity, held on April 15, 2015 at the AVR second floor, UPOU headquarters, given this 15th day of April 2015 in Los Baños, Laguna, Philippines, signed by Dr. Inocencio E. Buot, Jr., Dean of Faculty of Management and Development Studies. Okay. Someone. Ay, ano pa close? Sa ano, 'di ba? Sabi natin, I think yesterday some of the group members were telling me that this particular occasion should be called fellowship, right? So may academic and fellowship part. But before we end this program, I would like to call also Dr. Araceli Balabagno for the closing remarks, former Dean of the UP College of Nursing.
Thank you, Ma'am Rita, for the assignment. First of all, I'd like to thank Lorraine. That was a scholarly lecture. So let's give her a hand. Second thing I want to say is that I wish there were more nurses who would listen to your lecture. And that brings me to that kind of invitation that we would like to invite you. You know, I'm also with PNA, and I'd like to invite you to come and lecture to us. Give us the time. Okay? Third is that your invitation about being involved with your current focus on heart failure research. I'm very much interested in that. And I also would like to give some updates. Okay? Can I ask you how many are foreign-based? Nagtatrabaho sa offshore. Offshore. About half of the class, right? Yung nasa Philippines, ilan yung nasa Metro Manila? Okay. Can I ask you, this is in response also to some of the questions that has been raised. Are you familiar with the revision of the nursing law? Current nursing law. Has anybody read it? Oh. Kailangan po malaman natin yon. Because that addresses one of the issues that you were raising about being a nurse practitioner and independent nursing. It is there, it is stated there. So it's in the nursing law that one, in the scope of practice, one is allowed to do independent nursing. But I'd like to share some concerns. Okay? Ang isang observation, for example, in UP kasi we get visitors from other countries. One of their observation is that, you know, you have a very good curriculum in the Philippines. So when they evaluate the nursing curriculum of the Philippines, galing, pass tayo lahat. But when they had, for the last few years, when they had new nurses in their system, they had complaints about, for example, they're not too skillful in assessment, physical assessment. Okay? They're not too skillful in communication, interaction, and so on. So we were saying, where is the problem? So we're trying to analyze that kind of concern also in the Philippines. And it brings us to an assessment that something is wrong with the implementation of the curriculum in some colleges of nursing. Okay? Meaning to say they passed the board exam, no doubt about it, knowledge, right? memorize, ang gagaling. But in terms of practice, medyo kulang tayo doon. And then we sort of analyzed, okay, what could be some of the factors? One is that for the last 10 years, our colleges of nursing have bloated up in numbers, right? So dati, ano lang siya, 164. Then there was a year about 5 years ago, it reached to 4,000. 400, sorry, 400 plus. And take note, ilan lang ba yung ating tertiary hospitals, government hospitals, that would accommodate students for clinical practice? Ilan lang, di ba? So where do the other students go? For example, where do they go to complete their ano ba, deliveries? Okay. Where do they go to complete their uh, OR? Okay. Where do they go to practice assessment? So these are some of the questions that has come up. And we were saying that there must be a need to really work on this. So for the last 3-4 years, okay, the Board of Nursing, together with the Association of Deans of Philippine Colleges of Nursing, they've been working in the CHED, Commission on Higher Education. We have a technical panel for nursing education. Okay, so they have been working on the curriculum so that in 2012 they have identified and revised and promulgated, meaning to say accepted, a set of nursing national nursing core competency standards. And we would expect that the colleges of nursing, the hospitals would have some information about that, because the thrust is really to embed the core competency standards, because that would be the basis for establishing work performance, performance indicators, expectations for BSN. But unfortunately nga, not many still colleges of nursing and hospitals know about it. And that is the thrust of the Board of Nursing right now. So we're in the process of, I say we, because usually UP is part of that team, we are in the process of, ang tawag nila ay spreading the information about that and embedding them in practice and education. And we hope we can do that to help improve the performance of nurses. Okay, so isa yon sa ginagawa nila. So madami po, kaya lang we would like you to be involved also. Second thing lang, before I go, yung about the Magnet Hospital, we thank you for that information. In the Philippines, there is one who's working on that. This is Dr. Annabel Borromeo, St. Luke's Global City. And they have a 3-year project to work on that. The first step that they have is right now making sure that most of their nurses are not just BSN, but Master of Arts in Nursing graduate. Okay, and they have a very good research department who is now working on the steps for that Magnet Hospital. There are several tertiary hospitals in Manila. Okay, have you visited some of them? Have you visited Global? Very nice, isn't it? Have you visited Asian Hospital? Very nice, isn't it? So they're at par, actually. Medical City, for example. Who's from Medical City? Medical City is expanding to Guam, isn't it? So they're getting nurses from us. So it means to say that we're on that track, really to develop. The Department of Health, I think there was one question about developments, health developments. Okay. I think we're in that process. For example, Pinoy would like to make sure that every Filipino is enrolled in PhilHealth. Dapat nurses should help in sharing that information. Okay? Kasi sa atin, meron pa pong mga tao sa probinsya, sa rural areas, na ni minsan ay hindi pa po nakakakita ng health professional. And we are targeting them. Okay? We are helping them. Meaning to say, sana po yung ating mga nurses din would be involved in that kind of care. Gusto naming tumulong sa mga patients na nasa community. Kaya lang po, karamihan ng ating nurses, yun na nga po yung goal eh, makaalis papuntang abroad. But anyway, yun ang isang problema natin. Ngayon, ang Department of Health, okay, alam niyong devolution, right? Okay. Pero ngayon, meron pa rin tinatawag silang retained hospitals, regional hospitals. In Manila, there are 4 main centers, okay, who have worked together and they're developing programs for specialization. Okay, so they're working on that to improve practice. Umpisa sila syempre sa government hospitals, but there are many who are actually working on that. So in the Philippines, we have about 20 nursing specialty groups who have banded together in a coalition we call the Philippine Nursing Coalition Roadmap. And the current president is the former Honorable Betty Merritt. Okay? So they are one. Yung team na mahalaga eh, to make sure that all our ideas about how to improve nursing care are there. So these are some of the developments, and I wish that you can contribute in your own places, especially those in the provinces. Okay? At saka siguro yung last message na I really appreciate is start small. Okay? So when we start small, we start from our own institutions, from our own area of influence, and I'm sure that that is the one that would spark if we do it correctly, following the evidence-based protocols that you have mentioned. So I really appreciate this lecture. I also have learned, okay, and I wish we can have Dr. Lorraine Evangelista again. Ma'am Rita, please make sure. Okay. Okay. So salamat po. Good morning.